So this is a case of male 23 years who had a road traffic accident and had a crush injury of the foot. He had compound crush fractured talus, more so of the medial dome, and also had a compound shattered comminuted fracture of fibula. Now, it was at the end of 4 weeks after the debridement on the lateral side by a primary health center doctor who also pushed in 2 wires. He was referred to us for the definitive management. And this is how he came up with the X-rays at presentation. It is segmental fibula. Here there was a crush fibula which was involving the syndesmosis. There was a fracture of the neck of the talus as well as comminuted fracture of the dome of the talus on a medial side with these 2 K wires on in situ. So these were the X-rays. And then we thought that now we should not rely on somebody else's debridement. We went in, but before that we got a CT scan, and you can see that there is a great combination with loose pieces of talus on a medial side of talus. So this were the CT scan pictures, and we went in with surgery number 2 in form of revision debridement. We put in external fixator. We put in K wires for fibula. We excise all dead loose pieces of medial talus. And then there was a big gap into which we put in antibiotic impregnated cement spacer. The wound had to be treated with vacuum assisted dressing application. This was the dorsal view of the foot. This was the lateral view, and it was here where we had a wound issues. Uh, we put in a vac and we covered it with the vac. This is how it looked after application of vac, and this were the x-rays. We pushed in a wire from fibula to tibia, from fibula to talus, and tried to maintain whatever length we could maintain that of fibula. And we continued with that transcalcaneal pin which was put by the earlier surgeon, and this whole medial area was put in with the antibiotic impregnated spacer. This is how the picture looked on postoperative x-rays. So closer view, a cement spacer occupying the medial part of the talar dome, and it was after 2 vac applications the raw area became ripe to be grafted. There was no infection, wounds were healing. We went in, we removed the fixator, K wires are seen. This is how the condition looked after removal of fixator, and this were the x-rays at the end of 6 weeks where fixator was removed, uh, fibula was sizably, length was maintained with this 3K wires on and a cement spacer in. So Arvind, if I wish to generate a small discussion, can I ask your brains to help me? What next at the end of now 10 weeks post trauma? Serology is normal. There is no infection, no problem, no discharge from the wound. Everything is healed. What definitive management would you like to do for this patient?
So, how long has he had the cement spacer, Rajiv?
So it's about 6 weeks that he had cement spacer.
All right. And you've done some biopsies to see if there's any infection or aspiration.
Yeah, we have done 2 consecutive negative aspirations, and the serology CRP and procalcitonin and ESR have all settled down. They're normal.
Right. Okay. So, if he's already had the cement space for 6 weeks, he's already had IV antibiotics, his aspiration and biopsies are all negative, then I think the definitive procedure here, even though he's a young man, I would try and do a orthodesis for him. And with bone graft. His subtalar joint doesn't exist anymore, so I would not hesitate to try and do like a nail for him and put a lot of bone graft where the talus is missing. Um, Leave the talonavicular part of the talus intact, and like really keep a close eye on him. I would take more samples at the time of the surgery, keep him on IV antibiotics until all those samples are proven to be negative. I wouldn't stop the antibiotics as well.
Great point, Arvind. Now, he was a young guy and was always wanting to salvage the joints. So we thought of salvaging the joint. No question of doing total talus replacement because the 45 to 50% of the talus was intact. So the problems in front of us to salvage the joint were number one, precarious soft tissue envelope, segmental short fibula plus comminution and bone loss, and 55% of the talar body was lost. How to replace this talar body loss? And there was a posterior shell of neck, and how to fix the neck fracture. So we went in with this. For problem number one, for a precarious soft tissue envelope, what we did, we took in a medial approach, and the lateral approach was taken at the anterior border of the fibula to avoid the precarious soft tissues. A segmental short fibula with comminution and bone loss was restored with the fibular length and syndesmotic fixation plus a bone grafting into the defect. And 55% of talar body which was lost, we thought to replace with allograft talus. So allograft talus of whatever appropriate size we could get, that's very difficult to get in India. Somehow we managed to get a young patient's allograft talus. Obviously, it was not matching so greatly with the original talus. So surgery number four was allograft talus replacement. This is how the defect looked after removal of the cement spacer. We shaped the allograft talus, we cut the allograft talus to the size of the defect, and we matched at least the ankle part of the tallograft articular surface with the ankle part of remaining part of talus and pushed in two headless compression screws, and the posterior shell of neck was fixed with multiple uh, cancellous bone graft chips and was covered with the abgel and was passed with one screw. And this is how he went on to heal, and this is the final result. Just 15 days back, he sent me this video. He recently married and he's taking his uh, fiancée onto the scooter. He sent me this video of his movements, and he's gone back to his routine activities. Let's see how long this ankle lasts. But this is how we could definitely give him a better ankle than the fused ankle. So I rest my case here.